Neuroblastoma. Neuroblastoma, a tumor of postganglionic sympathetic neuroblasts. The sympathetic chain extends from the neck to the sacrum. The adrenal gland. Neurotransmitter catecholamines. Neuroblastoma. Epidemiology. Most common extracranial solid tumor. Incidence 10/million per year. 10% of pediatric tumors. Peak age 2 to 3 years. Greater than 90% cases before 5 years. Mostly sporadic, rare genetic associations. Most common neonatal tumor, neuroblastoma, genetics. Mostly sporadic, rare, 2%, genetic associations, NF1, Hirschsprung, congenital central hypoventilation syndrome. Mutations in ALK, tyrosine kinase. Environment. Neuroblastoma, biology. Neuroblastoma is a tumor of undifferentiated, embryonal, neuroectodermal cells, derived from the neural crest. An aberration of normal differentiation. An abnormal response to normal neurotropic signals, TRKA, NGF. Spontaneous regression. Differentiation, ganglioneuroma, ganglioneuroblastoma. Neuroblastoma, clinical features I. Tumor originates from sympathetic ganglia/adrenal gland. Lymphatic and hematogenous spread. Metastases to bone, liver, bone marrow, skin. Most patients present with advanced disease, 40% of all patients, 55% of patients over 1 year. Neuroblastoma clinical features, 2. Abdominal mass, 65%. Thoracic mass, infants. Bone pain. Fever. Weight loss. Sick-looking child. Neuroblastoma, clinical features, 3. Lower limb paresis, 20 to spine lepidural tumor, 4%. Severe diarrhea 20 to secretion of VIP, vasoactive intestinal peptide 4%. Horner syndrome, patients with cervical or upper thoracic sympathetic ganglia, 1.7%. Hypertension, flushing, sweating, 0.2%. Raccoon eyes. Pallor, bleeding diathesis, bone marrow involvement. Neuroblastoma. Raccoon eyes. Neuroblastoma, clinical features, 4. Opsoclonus myoclonus syndrome. Acute cerebellar encephalopathy characterized by cerebellar ataxia, rapid and random eye movements, opsoclonus, and myoclonic jerks, 2.8%. Good oncological but poor neurological outcome. Laboratory features: catecholamines, dopamine, epinephrine, VMA, HVA. Serum markers, LDH, ferritin, NSE, neuron-specific enolase. Blood count, BM involvement. Coagulation, liver involvement, metabolism of catecholamines. Pathology: small round blue cell tumor. Neuroblastic differentiation, from very undifferentiated to differentiated. Degree of anaplasia, Shimada index. Biological parameters. Neuroblastoma biology 2. N-Myc, oncogene on chromosome 2 amplification, worse prognosis. DI, DNA index equals ploidy, hyperdiploid, better outcome in infants. 1p deletion, putative tumor suppressor genes, worse prognosis. 17q gain, oncogene. N-mic amplification. Amplification, a localized genomic change that results in increased dosage of a gene or genes affected. Homogeneously staining regions, HSRs, are areas on the native chromosome with multiple 100 to 200 kilobytes copies of the region containing the amplified gene. Double minutes, DM, extra chromosomal fragments containing the amplified gene. Greater than 10 copies are associated with a worse prognosis. Mechanisms of N-mic amplification. N-mic amplification homogeneously staining region. N-mic amplification double minutes. Neuroblastoma 1p deletion. Neuroblastoma, staging. CT MRI. MIG, meta-iodobenzyl guanidine. Bone scan. Bone marrow aspirate and biopsy. Surgery. MIG scan. Neuroblastoma, staging. Stage. Tumor confined to organ of origin and completely resected. I. Tumor extending beyond organ of origin, ipsilateral nodes plus. 2. Tumor crosses midline, contralateral nodes plus. 3. Metastatic disease. 4. Less than 1.5 year, metastases to liver, skin, BM. 4S. Neuroblastoma, INSS staging system. Stage 1 localized tumor with complete gross excision, with or without microscopic residual disease, representative ipsilateral lymph nodes negative for tumor microscopically, nodes attached to and removed with the primary tumor may be positive. Stage 2A, localized tumor with incomplete gross resection, representative ipsilateral non-adherent lymph nodes negative for tumor microscopically. Stage 2B localized tumor with or without complete gross excision, with ipsilateral non-adherent lymph nodes positive for tumor. Enlarged contralateral lymph nodes must be negative microscopically. Stage 3, unresectable unilateral tumor infiltrating across the midline, with or without regional lymph node involvement, or localized unilateral tumor with contralateral regional lymph node involvement, or midline tumor with bilateral extension by infiltration, unresectable, or by lymph node involvement. Stage 4, any primary tumor with dissemination to distant lymph nodes, bone marrow, liver, skin, and/or other organs, except as defined for Stage 4s. Stage 4s, localized primary tumor, as defined for Stage 1, 2A or 2B, with dissemination limited skin, liver, and/or bone marrow, limited to infants less than 1 year. International Neuroblastoma Staging System, INSS. 1. 4. 2B. 4S. 3. 2A. Age, less than 18 meters, favorable. Prognostic factors. Age, less than 18 meters, favorable. Stage. Histology, Shimada. Biology. N-mic, DI, 17Q plus 1P. Neuroblastoma, treatment. Risk adapted. Low risk NB, minimal. Therapy, excellent outcome. High NB, intensive therapy, poor outcome. INRG- International Neuroblastoma Risk Group Classification System. Age. Stage. N-mic status. Neuroblastoma protocol assignment by risk group. Study. Risk group. DNA ploidy. Shimada histology. N-mic status. Age. INSS stage. Low risk. Low. Any. 0 to 21 years. 1. High risk. High. Dash. FAV. And FAV. Non-AMP. AMP. less than 365 547D, greater than 365D, greater than 365, 2A/2B, IM risk, high risk, intermediate, less than 365D, 3, 4, greater than 1, equals 1, less than 365, 4s, low/intermediate risk neuroblastoma. Watch and wait, no treatment equals no toxicity. Surgery minimize damage. Low intensity chemotherapy. Radiation, emergency only, rarely used. Improving survival for stage 4 neuroblastoma patients greater than 1 year of age at diagnosis. 0.8. Children's Cancer Group data. Probability of overall survival. 0.6. 0.4. 1986 to 1995 N equals 675. 0.2. 1978 to 1985 N equals 507. P less than 0.001. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 years from diagnosis. Treatment, higher risk neuroblastoma. Induction chemotherapy. Surgery. High-dose chemotherapy with stem cell. Rescue, eradication of residual disease. Radiation. Retinoic acid. Immunotherapy. Higher risk neuroblastoma, treatment roadmap. Induction surgery consolidation XRT cis-array immuna. Chemotherapy ABMT anti-GD2IL2. GM-CSF. Differentiation therapy. Immunotherapy. Chemotherapy in neuroblastoma. Platinum, cis, carbo. VP16. Doxorubicin. Cyclophosphamide/ifosfamide. Vincristine. Topotecan. High-dose chemotherapy. Myeloablative doses. Eradication of tumor. Rescue with autologous stem cells. MEG. Melphalan, etoposide, carboplatinum. BM. Busulfan, melphalan. Neuroblastoma, radiation therapy. Local consolidation, in high-risk disease. Massive hepatomegaly in infants with 4S. Cord compression. Metastatic disease, palliation, neuroblastoma, differentiation therapy. Cis-retinoic acid, Roaccutane. Induces differentiation of neuroblastoma cells in vitro and decreases proliferative capacity. Shown in randomized clinical trial to improve outcome. High dose, pulse retinoic acid induces neuroblastoma differentiation. Control. 10-retinoic acid. Neuroblastoma, immunotherapy. Anti-GD2 antibodies. Interleukin-2. GM-CSF, accrual of 386. Randomized patients. Needed. COG ANBL0032 Phase 3 the 17th of February 2009 Status, Data and Safety Monitoring Committee. With 61% of accrual in, and 2-year median follow-up, the immunotherapy arm shows superior EFS, P equals 0.0115. Superior OS, P equals 0.0223. Neuroblastoma, outcome. Stage I minus 95% 5 years EFS. Stage 2 minus 90% 5 years EFS. Stage 3 plus 4, 10 to 40% 5 years EFS. Stage 4S minus 95% 5 years EFS. 4's neuroblastoma not bone under 18 months primary tumor stage I/2. Metastatic disease limited to bone marrow less than 10%. Skin subcutaneous nodules. Liver. Not bone. Bone and bone marrow. Neuroblastoma, staging. Stage. Tumor confined to organ of origin and completely resected. I. Tumor extending beyond organ of origin, ipsilateral nodes plus. 2. Tumor crosses midline, contralateral nodes plus. 3. Metastatic disease. 4. Less than 18 months, metastases to liver, skin, BM. 4s. 4's neuroblastoma spontaneous regression cure with minimal therapy. Exception, massive hepatomegaly in less than 2 months. May require chemotherapy, RT. Neuroblastoma, spontaneous regression. Occurs mainly in 4's disease. But, may occur in all stages, overall 10% of cases. Screening studies detect a 2-fold increase in incidence of neuroblastoma compared to clinically detected cases. Cases detected in utero by ultrasound are being reported more frequently, and most are expected to resolve without treatment. Spontaneous maturation to ganglion neuroma is apparently less common, but there is little data. Neuroblastoma, outcome by stage. Mican amplification correlates with poor survival. In infants with stage 4 neuroblastoma, p less than 0.0001. Schmidt, JCO 2000. Potential therapy: radioactive MIG anti-GD2 antibodies, allogeneic BMT. Sequential auto BMT X23. Rapid sequence induction. Early detection. Targeted therapy, ALK inhibition. Neuroblastoma, screening. Rationale. Poor results in advanced stage tumors. Early stage, better outcome. Available tumor marker, CA. Method. Universal screening by urinary CA at 6 months. Neuroblastoma screening, results. More early stage tumors. No increase in detection of advanced tumors. No improvement in overall cure. Do advanced tumors evolve from early stage less aggressive tumors? Or are they rapidly evolving metastatic tumors that occur after 1 year of age? Perinatal neuroblastoma. Tumors discovered during routine antenatal ultrasound as adrenal masses. Differential diagnosis: adrenal hemorrhage, pulmonary sequestration. Traditional approach: surgery. Most tumors, stage 1, favorable histology, N-MIT non-amp. Postnatal MIBC scan. If positive. Close observation, surgery for growing tumors. Excellent outcome.